The complete pulmonary review for the USMLE, Step 2. I apologize for taking so long to get this video out, as I have been spending a ton of time producing what's going to be the absolute best resource for medical students online, with insane short videos to make studying extremely easy, covering microbiology, anatomy, and more. And as for our review, the slides will be available on my website, which is currently under construction, but without further ado, let's begin.
Question 1. By the way, these first few questions are on lung anatomy. Here we go. A chest tube is placed into the fourth intercostal space in the mid-axillary line to drain an empyema. After traversing the skin and subcutaneous fat, which muscle does it transverse? So we're at the fourth intercostal space in the mid-axillary line. Here's the mid-axillary line. Right at the middle of the armpit, going down, this would be the serratus anterior, as we could see over here. This is more of a step 1 than a step 2 question, but it still may come up. And here again is another image of the serratus anterior in red. And here is where the chest tube was placed. Soon we're going to go over where chest tubes are most commonly placed, and here was at the fourth intercostal space. And just to review some basic anatomy, serratus anterior is a muscle involved in scapular support and motion, and it's innervated by the long thoracic nerve, as you can see faintly over here in yellow. And in this annoying brachial plexus picture, we see the long thoracic nerve originating from C5, C6, and C7. All right, and just another point on lung anatomy. If you take a look at this picture over here, we see the clavicles, and above the clavicles we see the lungs. So again, the apex of the lung does in fact go above the clavicle. And this is why a lung can actually be punctured by a stab right above the clavicles, which I wrote over here. It could cause either a pneumothorax or a hemothorax. And here's another basic pulmonary question on lung physiology. The diaphragm goes up or down upon inspiration, and the answer is the diaphragm goes down upon inspiration. Most people don't know this. They intuitively think that the diaphragm goes up upon inspiration because your shoulders go up and your head kind of goes up. But in fact, the diaphragm goes down, and that's of course to make more room for incoming air. All right? So diaphragm down upon dinspiration. Yes, I said that purposely, upon dinspiration. D for down, D for dinspiration. And that wonderful rhyme that we all recall from first year med school, C3, C4, C5, keeps the diaphragm alive. All right, here's our ADHD summary of what we've learned so far. The lungs go above the clavicle, and the diaphragm goes down with dinspiration. All right, question 2. A woman gets an injection along the upper border of the 10th rib at the right mid-axillary line. Which structure is most at risk of damage? A nerve, the lung, or the liver? Well, it's not a nerve, because a nerve would be along the lower border of the rib. And since we're at the 10th rib, this is more likely going to be an organ and not the lung, so here it's the liver. Injections below rib 9 are more likely to injure abdominal organs and not the lungs. And again, since it was the upper border, it's most likely not a nerve. The intercostal vessels lie along the lower border of the ribs. All right? And here are just typical thoracentesis locations. Between the 6th and 8th ribs at the midclavicular line, between the 8th and 10th ribs at the midaxillary line, and between the 10th and 12th ribs at the paravertebral line. Question 3. The phrenic nerve carries pain fibers from the visceral pleura or the parietal pleura, and the answer is the phrenic nerve carries pain fibers from the parietal pleura. P for parietal and P for pain. And that innervation that we're talking about is the phrenic nerve. 3 P's. And just a reminder, the parietal pleura is the outer boundary of the pleural space, whereas the visceral pleura covers the surfaces of the lungs. The phrenic nerve, which is innervated by C3 to C5, brings motor innervation to the diaphragm, as well as what we spoke about just now, it carries pain from the parietal pleura. And just to remember, this can cause shoulder pain, referred pain to the neck and shoulder, since again it originates from C3 to C5. All right, question 4. Which lung is more prone to aspiration, the right lung or the left lung? And if you recall, it's the right lung. The bite goes to the right. If you bite and it goes down the wrong pipe, it goes to the right. Not down the esophagus, but down the trachea into the right lung. And this is because the right main bronchus is very wide, short, and vertical. And we can see that over here. We see the right main bronchus is short, it's wide, and it's more vertical. Gravity will take the food into that lung. All right? And here we see another picture of that short right main bronchus right over there. The right main bronchus and the left main bronchus. Again, the right one is short and wide and vertical. Now, upright patients tend to aspirate food, and that's why upright patients tend to aspirate into the right lower lobe, again because of gravity. In contrast to bedbound patients, They aspirate primarily into both A and B. And again, this is because of gravity, but let's explain a little bit more. Bedbound patients, or recumbent patients, who experience aspiration involve the superior portions of the lower lobes and the posterior portion of the upper lobes. Let's take a look at a picture. Here we have the 3 lobes. This image, by the way, I created to make this easier to visualize. We see the upper lobe and the lower lobe. So if a person is lying down, they're in the recumbent position, then the food will affect both the upper and lower lobes, as we can see over here. All right, 6, we moved on to anatomy, and now we're discussing pulmonary infections. A 10-year-old boy with cystic fibrosis has had a 3-day history of fever and productive cough. IgE levels are really high. What's the diagnosis? Bronchopulmonary aspergillosis, and that's explained by the high IgE levels. In hypersensitivity pneumonitis, we see normal IgE levels. It's a type 3, primarily type 3, as well as a type 4 hypersensitivity reaction, but IgE levels will be normal. Bronchopulmonary aspergillosis is something associated anyway with cystic fibrosis. All right, here's a little bit about allergic bronchopulmonary aspergillosis, seen in cystic fibrosis patients, IgE response, and we treated with systemic steroids to decrease the allergic response and antifungals. All right, question 7, the mechanism of pneumonia hypoxia is... Here we see the pneumonia, the infection, an infection of the lungs by this gram-negative rod over here. Well, which gram-negative rod is going to cause pneumonia? It could be Pseudomonas, Klebsiella, and Acinetobacter. These are gram-negative rods that could cause pneumonia, but not relevant to our question over here. What's the mechanism of pneumonia hypoxia? It's a VQ mismatch. And that's because as the alveoli fill up with inflammatory infiltrate, there's decreased ventilation in that part of the lungs, so there's decreased ventilation causing a VQ mismatch. In diffuse pulmonary hypoventilation, that's not typical of pneumonia. That's seen in something like a drug overdose, where it affects all of the lungs, diffuse pulmonary hypoventilation. All right, question 8. A major complication of RSV in newborns, that is less than 2 months, is, and the answer is apnea. Babies with RSV can get apnea. Now, it's not just babies, it's children and adults also, but it's more severe in babies, especially when they're less than 2 years old, and especially when they're less than 2 months old, as their lungs are not fully developed. They can develop lower respiratory distress. And this is through the bronchiolitis, the inflammation of the small airways caused by RSV. Now over here, I just wrote a note that this may show up on the boards actually. It's a new drug from 2023, and the CDC encourages all infants less than 8 months to get nirsevimab, a monoclonal antibody which works like a vaccine to prevent RSV. Nirsevimab should be given to infants to prevent RSV. And we can remember this because nirsevimab stands for no RSV man. Nirsevimab, no RSV man. Nirsevimab. Question 9. Pneumonia in COPD patients is most commonly due to... The answer is Haemophilus influenza, Moraxella, and strep pneumonia. And we can take a look over here. Associations of these microbes with various conditions. For example, Staph, Pseudomonas, and Burkholderia capacia are seen in cystic fibrosis patients who have poor mucociliary mechanism, and they are more prone to these infections. You can take a look at these associations over here. Question 10. Pneumonia diagnosis entails... Now, the truth is, I want you to throw question 10 out because it's not such a good question. But technically, pneumonia diagnosis requires both symptoms and imaging. But the truth is, the reason why this is a bad question, and you can take a look at these notes on the bottom over here, is because it's possible in the hospital to make a diagnosis of pneumonia, for example, based on imaging alone. Imagine a patient is unresponsive in an acute condition, for example, and we look at their chest x-ray or their CAT scan, and we see clear evidence of pneumonia. We don't need to look for symptoms of an acute respiratory infection to diagnose pneumonia. The imaging alone would be enough. But just so you know, pneumonia technically requires imaging for diagnosis, and of course, if the patient is conscious, and we see this usually goes along with at least 2 symptoms of acute respiratory infection. So you can throw question 10 out, and on the bottom over here, I just made mention of some tests for specific pathogens. All right, question 11. Back to first aid. Which findings are most associated with pneumonia? Will there be dullness or resonance? There will be dullness because of all the fluid that builds up. And there will be increased tactile phremonus. Tactile phremonus is evidence of consolidation, and that's what we see in pneumonia, as well as in pulmonary edema. Again, both the dullness and the increased tactile phremonus. This is in contrast to, for example, atelectasis, where although there will be dullness to percussion, there will be decreased tactile phremonus. Question 12. Pneumonia and diarrhea is most associated with Legionella. In Legionella, we see pulmonary symptoms, GI symptoms, or even CNS symptoms. Question 13. What respiratory rate is significant regarding the question of whether to hospitalize a patient with pneumonia? And for this, we need the curve 65. It's bigger than 30. Let's take a look. Curve 65. Thank you, Dirty Medicine, for this chart. Here are the criteria for hospitalization. You have to have 2 of these criteria. Confusion, BON more than 20, respiratory rate more than 30, blood pressure less than 90/60, and age more than 65. And notice in this chart, we don't consider imaging regarding the question of whether to hospitalize a patient. And this is because, for example, a chest x-ray can't reveal the severity of the hypoxia. We need the lab values, or see confusion. Now, I just wrote a note over here that even though, according to curve 65, technically you need 2 points to be inpatient, but in practice, either hypoxia with a PO2 less than 60, this should have been 60, not 6, or hypotension systolic less than 90, alone would be sufficient enough to hospitalize a patient with pneumonia because it's getting pretty severe. Question 14. Inpatient treatment of pneumonia is with, I already wrote the answer, azithromycin and ceftriaxone. Azithromycin to cover the atypicals and ceftriaxone to cover the typicals. Now, ceftriaxone is given instead of, for example, amoxicillin because it's given IV, and that has better tissue penetration. So if you're giving both azithromycin and ceftriaxone, you're most probably going to be covering whatever bug is causing the pneumonia. So just keep this in mind. For board's purposes, we want to give a drug that covers both a typical and an atypical. Amoxicillin and doxycycline, that's generally for outpatient, and inpatient gets a macrolide plus either a beta-lactam such as ceftriaxone or a fluoroquinolone such as levofloxacin or moxifloxacin. All right, question 15. The most common finding of TB among typical hosts is a cavitary lesion in the upper lobes. Very few things affect the upper lobes, but TB affects the upper lobes. Another thing that would affect the upper lobe would be aspergillus. Again, we see a cavitary lesion in the upper lobe. It's not so typical among infectious causes. For example, sarcoidosis can affect the upper lobes. And here we see another image of TB in the upper lobe. We see a cavitary lesion, which is basically a walled-off portion with infectious material inside. Now, if it gets really infectious, it could be called empyema, but this is the cavitary lesion. Now, TB in the upper lobe is usually associated with the latent infection. And if you take a look over here on the bottom, HIV patients are the ones with primary TB who may show lower lobe infiltrates. And if we see it all over the place, that's miliary TB. That represents hematologic or lymphatic dissemination. All right, question 16. Alcoholics and recent immigrants require which size iteration to be considered positive for PPD? And the answer is 10. It's going to be 5 if they're very high risk, 10 if they have mild risks, such as healthcare workers, and 15 if there are no risk factors. All right, I had a picture over here, but not sure where it went. So again, medium risk, bigger than 10 millimeters. Question 17. Once TB is diagnosed, what is the treatment regimen? And you can take a look at that over here. Rifampin isoniazid, pyrazinamide, and ethambutol for 2 months, then rifampin isoniazid for 4 more months. And we change that for various conditions such as osteomyelitis. And in pregnancy, we don't give pyrazinamide. All right, question 18. Which anti-TB medication causes hyperuricemia? And the answer is pyrazinamide causes hyperuricemia. It can cause gout. But we don't worry about this until there are symptoms. Rifampin causes a red-orange discoloration. Isoniazid can cause peripheral neuropathy. That's why we give vitamin B6. And ethambutol can cause optic neuritis and eye problems. All can cause hepatotoxicity, but should not be stopped unless transaminases go up 3 times to 5 times the upper limit. This is terrible font over here, but I just wrote that we treat TB even if the acid fast is negative because it's only 50% sensitive. Question 19. Which is useful in a symptomatic patient suspected of having TB? And the answer is neither the IGRA or PBD. We don't give these in a symptomatic patient. We get the sputum acid fast testing, which again, as I said before, is only 50% sensitive. We're going to anyways treat the TB if there's a high suspicion of it. And I wrote over here that everyone with a reactive IGRA or PBD should have a chest x-ray to exclude active disease. If the PBD is positive, the patient must be treated regardless of past BCG immunization. And this is even though the BCG will typically render the test positive. Question 20. What is the treatment for a positive IGRA or PPD in a patient without active disease? So again, the patient has latent TB, isoniazid, and B6 plus rifampin for 3 months, or rifampin for 4 months, or isoniazid plus B6 for 9 months. So it's not as intense as the full-blown TB 4-drug regimen, but the person still needs to be treated. All right, question 21. Which is true regarding asthma? And for learning purposes, I wrote all of the above. It's reversible, as opposed to, for example, COPD. It's one of the obstructive conditions, along with COPD, bronchiolitis, and cystic fibrosis. And that means that it's harder to exhale. Exhalation is the problem. There is prolonged expiration, and I over E goes down, meaning it's harder to get air out. So expiratory phase goes up, I over E goes down, and pulsus paradoxus is possible, not just in cardiac tamponade. And you can take a look at the notes that I wrote on this page over here. Question 22. Which is the best initial test for asthma? And the answer is spirometry. And we want to look for an FEV1 over FVC less than 70%. And I wrote over here that the methacholine challenge is not the best initial test. It's the most accurate for an asymptomatic patient. So spirometry is the best initial test for asthma. And you could take a look at asthma diagnosis up here in green. Question 23. What should you do in an asthma exacerbation if PaCO2 is above 50? And the answer is intubation. If there's an asthma exacerbation and PaCO2 is so high, that means they're not blowing off the carbon dioxide. Their muscles are getting too tired and they are decompensating. It's a sign of imminent respiratory failure. We want to get this value of PaCO2 very low. Question 24. All asthma patients get which vaccines? And the answer is influenza every year and pneumococcal. Over 25 million people in the US have asthma, and over 250 million people in the world. They should be getting these vaccines. Question 25. What's the first step in treating mild asthma? And the answer is albuterol alone. I wrote over here, or purbuterol. Not formoterol alone. We never use alaba alone. It increases mortality, actually, in asthma patients. But using formoterol with a steroid may be a reasonable early option, but since we may be dealing with mild or intermittent asthma, we want to go with albuterol alone. I just wrote a note over here that the greatest risk factor for life-threatening asthma is a history of respiratory failure, which is defined as prior intubation or need for mechanical ventilation. Question 27. The side effects of inhaled steroids are dysphonia and oral candida. We see weight gain and leukocytosis in the systemic steroids, but in the oral ones, in the inhaled ones, we see dysphonia as the vocal cords are irritated and oral candida as there's suppression of the oral immunity due to the inhaled steroid. Question 28. A something-year-old man, I'm not really sure why I didn't write an age. I think I made this mistake on several of the questions, but it's quite funny. We'll call him a 50-year-old man. With a history of asthma comes in with shortness of breath, cough, sputum, expiratory wheezing, and prolonged expiratory phase. Respiratory rate is 34, which will help indicate the severity of his asthma. And the answer is the respiratory rate. Such a high respiratory rate. Imagine breathing at 34 times a minute. That is a clear sign, clear evidence that the person is about to decompensate. Now, you may have picked use of expiratory muscles, but the answer is that expiratory muscle use is a little bit subjective. It's not as good of an indication as respiratory rate. You can take a look at that over here. Question something 9, maybe it was 29. Which of the following increases survival in patients with COPD? And the answer is, you have to know this for the boards. They love asking this, that oxygen and putting an end to smoking. Oxygen, supplemental oxygen, and putting an end to smoking are the best ways to increase survival in patients with COPD. And in fact, these are the only two ways to increase survival in patients with COPD. Things like steroids and dilators don't help with survival, they just help with symptoms. But to increase survival, oxygen, and stop smoking. You can take a look at these notes over here. Question 30. A 35-year-old woman, smoker, coughing, diphenhydramine didn't help, cough has white sputum. Basically, we have a woman over here who has chronic cough. 4 months of coughing, but no indication. Now, this could be evidence, for example, of bronchitis. We need to check out what's going on. We get the PFTs. So basically, we want to find out the origin of her chronic cough. Causes of chronic cough could be upper airway cough syndrome, GERD, and asthma. That's what we want to get, the PFTs, to get her a better idea of what's going on. I wrote that over here. Question 31. A heavy smoker has exertional dyspnea, distant heart sounds, and his x-ray is shown. What is seen? So this is just something that we need to remember, that in COPD, we're used to the barrel chest, and that's usually what we look for. Doctors don't actually typically look for the sternophrenic angle, but for board's purposes, we need to know that it's bigger than 90 in COPD patients. All right, here's the sternophrenic angle. It's bigger than 90 degrees in COPD patients. Question 32. Which asthma medication causes cardioneurotoxicity? And the answer is theophylline. And that's because it has a similar action to stimulants. It can cause cardioneurotoxicity. It can even cause anxiety and hallucinations. In terms of its mechanism on the lungs, it inhibits phosphodiesterase, causing bronchodilation. Question 33. Another blank-year-old man. A blank-year-old man with a BMI 51 and high blood pressure has had a 3-month history of progressively worsening dyspnea on exertion. He also complains of awakenings at night due to choking sensations. Breath sounds are normal. So what's going to be found? So he has obstructive sleep apnea. He basically has a buildup of carbon dioxide in his body, so he will not have decreased carbon dioxide, he will have decreased chloride. As the carbon dioxide goes up, the bicarb goes up, And in the kidney, there's an exchange of bicarbon chloride. So there's increased bicarb retention and a decreased chloride absorption, decreased chloride. Doctors generally look for this value, chloride, when assessing such a patient, but for board's purposes, we need to understand the mechanism. So sleep apnea, decreased chloride. Question 34. A patient with what looks like an acute COPD exacerbation is treated with bronchodilator steroids, antibiotics, and O2. He develops lethargy, confusion, and asterixis. Which test will tell us the cause of his neurologic symptoms? And the answer is the ABG. We're not dealing with a liver condition. And by the way, ammonia is becoming less favorable anyway for assessing hepatic encephalopathy because they don't necessarily correlate. But anyway, we're not dealing with a liver condition at all. We're dealing with a lung issue. We want to get the ABG levels to look for hypercapnic encephalopathy. That is, the retained carbon dioxide in COPD patients can cause neurologic symptoms. By the way, this is one of the reasons why in COPD patients, we want the oxygen goal is about 90%. It's not 95%. We want to keep the oxygen low. Supplemental oxygen in such patients can precipitate hypercapnia because higher levels of oxygen could affect the gas exchange and make it harder for CO2 to get out. All right, a 60-year-old woman has an acute exacerbation of COPD. She is given IV antibiotics, prednisone, and 2 treatments of nebulized ipratropium with albuterol. She still uses accessory muscles to breathe. Pulse ox is 89%, which, as we just said, is okay. Pulse ox in COPD patients, we want to keep at about 89-90%. And PCO2 is 63, which is high. What's the next step? So this is a classic presentation of a COPD exacerbation, and we want to go with a CPAP or a BiPAP. This is how we deal with retention. Now, the way to think about positive pressure and ventilation, you know how we have COPD patients that use their pursed lips to help them get the trapped air out of the alveoli? That's exactly how this works. It's like a mechanical way of producing what pursed lips tries to accomplish. It makes it easier for trapped air to get out. And that's what's going on over here. That's what we want to do. All right, you can take a look at that over here in more professional terms, but I like my analogy a lot. All right, question 36. Which value is decreased in COPD? Oh, I can't stand these, but I just memorize it because I'm just too lazy to actually have to think about it. And that's FRC, RV, and TLC are all increased in COPD. Again, FRC, RV, and TLC are all increased in COPD. What will be decreased? Vital capacity. But basically, the person's lungs in COPD gets a lot bigger because of all the dead space, but the vital capacity, what they're actually breathing, is decreased. Question 37. A 30-year-old male in no acute distress uses a reliever inhaler on most days. This is becoming more persistent. So, what is the most appropriate initial therapy? So you want to go with a steroid, low-dose steroid, the inhaled corticosteroid, low dose, and a LABA daily. We don't just want to go PRN. We want to do it daily because this is persistent asthma. Persistent asthma is diagnosed if the person has nocturnal waking or a reliever inhaler on most days, or they have a reduced FEV1. All right, another question 38. A lady has exercise-induced dyspnea, cough, and chest tightness. For this, we give budesonide formoterol 10 minutes before exercise. The board just wants us to know that for exercise-induced asthma, we give this combination of the ICS, budesonide, and the beta agonist. You can take a look at the notes over here. Question 39. There's a lady who has albuterol, and now she develops muscle weakness, hand tremors, and decreased deep tendon reflexes. So what's the next step? Do we stop the steroid? No, we check her electrolytes, because what's going on over here is that she was given albuterol at high doses. They love asking about this. She had albuterol at high doses, and that can cause hypokalemia. Remember, albuterol causes hypokalemia because albuterol gets potassium into the cells. That's why sometimes in hyperkalemia, we give albuterol. Mainly we give the calcium and the insulin, but albuterol may also be given to facilitate therapy because albuterol brings potassium into the cells, causing hypokalemia. And that's what's going on over here. That's why she has these symptoms. Symptoms include muscle weakness, decreased deep tendon reflexes, as opposed to, by the way, beta-2 agonists. That's what's going on over here. Question 40. The only thing we need to focus on over here is that there's dullness percussion on the right with diminished breath sounds over the right lower lung. So this is a case of atelectasis. Atelectasis will cause dullness of percussion on the right with diminished breath sounds over the right lower lung because the right lung is collapsed. As opposed to a pneumothorax, we'll hear hyperresonance in the left lung and it won't really affect the right lung. Well, it's an extreme case, but in this question over here, we were dealing with an extreme case. This is most likely atelectasis. And you can take a look at the notes over here. Question 41, initial treatment of an acute exacerbation, blah, 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 blah. Which medication do we give after an asthma exacerbation? We give prednisone to help deal with the inflammatory response, to dampen the late phase inflammation and prevent symptom relapse. Question 42, This is a classic question of a patient with acute asthma exacerbation who now develops leukocytosis with neutrophil predominance, and this is due to the marginalization. This is a medication effect. Steroids cause leukocytosis through mobilization of marginated neutrophils and an increase in the number of circulating neutrophils. All right, question 43. The diffusion capacity of the lung for carbon monoxide is decreased in emphysema due to the destruction of the alveoli. I just wrote a note on the side over here. Chronic bronchitis is defined as productive cough for more than 3 months over 2 consecutive years, not due to other causes. Question 44. In obesity, hypoventilation syndrome, the primary cause of the dyspnea is alveolar hypoventilation, as the patient has more difficult time getting the air out. All that extra fat is making it harder for the person to get air out. There's no lung pathology inherently. It's an alveolar hypoventilation issue. And lab values will show hypercapnia, hypoxemia, and respiratory acidosis as a result of the inability to breathe the air out and the buildup of the carbon dioxide. Question 45. This is just an interesting question, probably won't come up. Came up in a UWorld question about paradoxical vocal fold motion, and that's what's going on over here. Paradoxical vocal fold motion. It's an inappropriate closing of the vocal cords during inspiration versus tracheomalacia, which is during expiration, and is caused by exercise, smells, or stress, and results in laryngeal obstruction and an inspiratory stridor. Probably won't come up on the exam, but here it is. Question 46. What is the most common trigger of COPD exacerbation? Interesting, I put the question in here, but it's URI. For example, a patient comes in with 1 week history of low-grade fever, runny nose, and productive cough, and now he's coughing much more frequently. There could be a change in cough, severity, frequency, sputum production, or levels of dyspnea. 46. An acute asthma exacerbation is treated with albuterol and steroid. If there's significant respiratory distress, for example, there's accessory muscle use, we give ipratropium for bronchodilation. And a systemic steroid should be given in all cases to treat the underlying inflammation contributing to the bronchial narrowing. 47. We have a smoker who has dyspnea, cough, and PFTs show FEV1 over FEC is less than 70%. This is COPD. What's the best way to improve mortality? As we said, well, actually over here, between these two choices, which generally decrease mortality, the best one is to stop smoking. By the way, the answer on the exam is always stop smoking. Answer on the exam. Supplemental oxygen, by the way, generally does improve mortality, but over here, the pulse ox is 93%. This person does not need to improve their oxygen anymore. We want to stop smoking. As I said, long-term oxygen is only beneficial if the oxygen saturation is less than or equal to 88%. 48. What's the primary player involved in the pathogenesis of aspirin exacerbated respiratory disease? And this is leukotrienes. They're involved. And here, exacerbated respiratory disease has a triad of asthma, chronic rhinosinusitis with nasal polyposis, and NSAID sensitivity. Leukotrienes. You could take a look at these other mediators, what they're involved in. For example, IgE and anaphylaxis. Question 49. A 55-year-old smoker has been coughing up blood and has lost weight. Calcium is high, hilar mass. What's going on over here? Remember, calcium high is in squamous cell carcinoma of the lung. It usually presents as a hilar mass. It's associated with cough, hemoptysis, and hypercalcemia due to the PTH-RH. Versus small cell carcinoma, there's no hypercalcemia. This one is associated with SIADH and ACT production. And Lambert-Eaton syndrome, which I didn't put over here. Question 50. A 52-year-old woman has progressive right shoulder pain radiating to the arm and Horner syndrome. What's the next step? So this is SVC syndrome. We want to get a chest x-ray. SVC syndrome, for example, due to a Pancoast tumor.
Question 51. A 20-year-old woman with no family or smoking history has had 3 episodes of pneumonia over the last 5 months. A tumor is found, which is most likely. So it's the bronchial carcinoid tumors and these types which cause the obstructions, which cause the recurring pneumonia, bronchial carcinoid tumor. It's in the same portion of the lung. I didn't write that in the question. Bronchial carcinoid tumors are the leading cause of cancer in adolescents and young adults, and it's characteristic that since they can occur in the same portion of the lung, they can cause a recurring pneumonia. 52. A 33-year-old woman presents with a recurring episode of abrupt onset fever, dyspnea, cough, and fatigue. Episodes resolve in a few days, and CT scan shows bilateral micronodule interstitial pattern. So it resolves, so this is actually a hypersensitivity pneumonitis, which looks a lot worse than it actually is. But it's interesting that it causes the micronodular interstitial pattern in both lungs. All right, I wrote a little bit about that over here. Question 53, a patient with small cell lung cancer now presents with serum sodium that is very low. Whenever you see lung cancer with low serum sodium, think of SIADH, and that's what's going on over here. And therefore, we want to give fluid restriction. This is a classic board's relationship, and they love asking about this. Lung cancer and SIADH. Remember, it's not just medication that cause SIADH, it's also trauma and malignancy. And I wrote a little bit over here. 54, 24-year-old male has 3 months of progressive dyspnea, non-productive cough, hypercalcemia, and a chest x-ray showing mediastinal fullness and scattered reticular opacities in the upper lungs. What will the PFTs most likely show? So the hypercalcemia and the lung symptoms over here point to sarcoidosis, and in sarcoidosis we see a normal FEV1. It's in COPD that we see a decreased FEV1. Here we're talking about sarcoidosis, there's a normal FEV1. Here, the description was about hilar lymphadenopathy that was causing the mediastinal fullness and the scattered reticular opacities in the upper lobe. And I wrote over here that sarcoidosis follows a restrictive pattern, and there will be a decreased DLCO because inflammation and scarring impede the alveolar gas exchange. That's what we see in sarcoidosis. 55, a 50-year-old male smoker has worked as a plumber for 20 years, has worsening dyspnea. CT shows reticular opacities of the lower lung fields, multiple plaques, and a round 7-centimeter mass in the right lower lung field. Not a good sign. What will most likely be found in biopsy? So here we're talking about asbestosis, and that's associated with mesothelioma, but most associated with bronchogenic carcinoma. Don't forget about that. Even though there's an association with mesothelioma, it's with the carcinoma that there's the highest association. 56, a longtime smoker has clubbing of his fingers and sudden onset bilateral wrist pain. What's the next step? So here we want to get a chest x-ray because malignancy, cancer can cause this hypertrophic osteoarthropathy. 57, a 57-year-old woman has progressive shortness of breath. On exam, decreased breath sounds and dullness percussion are noted on the right, middle, and lower lobes. Here we see the chest x-ray. What's the next step? So here, with all the fluid, we want to get a thoracentesis. Here we have a pleural effusion, and the first step is always thoracentesis to determine if it's transudative or exudative. And just a hint, unless there are signs of chronic heart failure, then give a diuretic to get rid of all the extra fluid. 58, an incidental 2-centimeter coin mass is found in the periphery of the right lung of a woman who is being evaluated for shoulder pain. What's the next step? Here we want to ask for previous x-rays for comparison. That's always the first step. If no films are available, the CT should be done to further describe the lesion. Question 59, a longtime smoker has digital clubbing. The most likely cause is, it's actually malignancy. Common causes of clubbing include cystic fibrosis, shunts, and lung malignancies. COPD itself does not cause clubbing, so in the case of a patient with COPD who has clubbing, you need to look for an occult malignancy. 60, a 34-year-old non-smoker man has a 3-week history of hacking, non-productive cough that is worse at night. He has had a URI a month ago that resolved except for the cough. Vital signs and PR are otherwise normal. What's the next step? So here he has this cough that continues. We want to give an antihistamine. The diagnosis is actually confirmed by giving the antihistamine, and we see elimination of the nasal discharge and cough. That would be a diagnosis of upper airway cough syndrome. And just in terms of definition, subacute cough would be 3 to 8 weeks, and chronic would be more than 8 weeks. If there's no response, then we're going to have to investigate further, for example, with imaging and PFTs. Question 61. A 2-centimeter lung nodule in a 65-year-old male smoker should, of course, be excised because it's bigger than 1 centimeter and he has risk factors. If it's bigger than 1 centimeter, then it generally does need to be removed, but for sure in a smoker, and for sure when it's 2 centimeters. 62. A baby was sick last week. This is his x-ray. What is seen by the arrow? This is actually just the thymus. 62. A 67-year-old male has dyspnea, inspiratory crackles, and CT of the chest showing reticular opacities and subpleural honeycombing. What's the treatment? So here we're just dealing with idiopathic pulmonary fibrosis, and you just got to know that the medication for this is pirfenidone. Pirfenidone for idiopathic pulmonary fibrosis, and you can take a look at the notes over here. 64, a 6-year-old man smoked a pack of cigarettes for 20 years but quit 10 years ago. What is the recommendation? We want to get CT scan every year because you have to be off smoking for 15 years in order to be considered like the rest of the population. But this guy needs to get it every single year because it's only been 10 years. 65, postoperative atelectasis can be most effectively prevented by deep breathing exercises. You can take a look at the notes over here. I got a lot of them, but I wrote over here on the side that atelectasis is one of the most common postoperative pulmonary complications and is particularly common after abdominal and thoracoabdominal surgery. 66, blah, 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 a lung condition, not CMV. CMV doesn't cause lung conditions. What's the diagnosis? Well, it's not, I'm not even going to look at the question because we take a look, we see a cavitary lesion. Pneumocystis cerevisiae pneumonia doesn't cause a cavitary lesion. It causes ground glass opacities that are diffuse. Invasive aspergillosis causes the cavitary lesion, especially in the upper lobe. Remember, 2 infectious things cause upper lobe pathologies, TB and aspergillosis. All right, you can take a look at the notes over here. I actually made a note about the halo sign, and in aspergillosis, some key terms to look out for are halo sign, and we can also see hemoptysis. 67, the single biggest risk factor for TB is recent emigration from China, Mexico, India, and Philippines is the single biggest risk factor. We don't see it too much in America. These are the risk factors. All right. And other endemic areas include Vietnam, Dominican Republic, and Haiti, especially when they've arrived in the last 5 years. Question 68. A 7-year-old patient with advanced Parkinson's is now coughing and has shortness of breath. He has had pneumonia twice over the last 5 months. He gets a sputum culture revealing polymicrobial organisms on sputum stain. Besides antibiotics, what is indicated? And the answer is a swallow study. And that's because a major cause of death in patients with advanced Parkinson's is bacterial aspiration pneumonia. So that's why we want to get a swallow study as the disease progresses. And you can take a look at the other notes that I have over here. 69. A 3-year-old girl has had a fever, shortness of breath, and signs of pneumonia. Pleural effusion is seen on chest x-ray with fluid analysis showing pH 7.2, elevated LDH, and low glucose. In addition to elevated leukocytes, what is the diagnosis? It is an empyema. Low glucose, think empyema. Low glucose, empyema. And of course, that explains the neutrophil count. Question 70. A child with pneumonia has had a sputum culture revealing strep pneumonia. Chest x-ray shows a right lower lobe infiltrate. He started on ampicillin and ceftriaxone. 3 days later, there is no improvement. What's the next step? We want to get a repeat chest x-ray. Because here, we have a child who's on antimicrobials with no improvement, so we want to look for a parapneumonic effusion. And we may require drainage that's indicated for moderate or large effusions or those causing respiratory distress. We don't add azithromycin because we've already cultured the patient and it showed strep pneumonia, so we know that it's not an atypical causing the symptoms here. It's strep pneumonia. We just have to figure out why it's not going away. 71. A 2-year-old girl has had upper respiratory symptoms, temperature is 100, wheezing, crackles, and respiratory distress. What's the treatment? This is supportive care. This is bronchiolitis, commonly caused by RSV, and it's self-limited in older children. But even in children, treatment is supportive. Palivizumab is actually a monoclonal antibody that's used as prophylaxis for those who are at high risk. And by the way, we mentioned at the beginning of this lecture another monoclonal antibody. Remember the one that starts with an N? That's recommended now to give routinely to infants. 72. A woman with a day history of nasal congestion, sore throat, and dry cough now with a cough with blood-tinged sputum. She has scattered bilateral wheezes and crackles. Chest x-ray shows clear lung fields. Temperature is 98. She's a non-smoker. What's the next step? So this is just actually a classic case of acute bronchitis. The next step is symptomatic treatment. For acute bronchitis, even though we get scared off by the blood-tinged sputum, but that's actually pretty normal in acute bronchitis, and that's what's going on over here. 73. Increased breath sounds and dullness percussion is seen in lobar pneumonia. In lobar pneumonia, we see increased breath sounds and dullness to percussion, as we said before. There's dullness because of the fluid. And the reason why there's increased breath sounds is again because of the fluid, as sound conducts more rapidly and efficiently through consolidation. 74. Cystic fibrosis plus non-resolving symptoms of lower respiratory inflation and high IgE. We said this before, bronchopulmonary aspergillosis. In hypersensitive pneumonitis, we don't see elevated IgE. 75. Actually, we already had this question. I'm not sure why we have it again. Pneumonia VQ mismatch. 76. A CF patient with recurrent episodes of dyspnea, fever, sputum production, and hemoptysis is experiencing. This is a bronchiectasis exacerbation, and bronchiectasis is described by a bronchial thickening and dilation. 77. A blank-year-old woman, I'm not really sure why she doesn't have an age, but if you ask me, she kind of looks like she's maybe 42, that's totally random, has a 10-year history of recurrent sinopulmonary infections with voluminous thick sputum and now has worsening hemoptysis. What's the diagnosis? So again, this is another probably cystic fibrosis patient, and she has these recurrent pulmonary infections, thick sputum. So here again, bronchiectasis, you can take a look at the notes over here. 78. A 7-year-old man on prednisone for vasculitis develops confusion, cough, and fever. Crackles are present over the right lower lobe. Chest x-ray reveals no abnormalities. What's the next step? So here we want to get a CAT scan of the chest. It could be that the chest x-ray reveals no abnormalities because he's on prednisone, and that causes immunosuppression, but there's actually maybe a pulmonary infiltrate that we need to identify with a CAT scan. The next step would be to get a CAT scan. 79. A 27-year-old female has had a dry cough that has persisted since she has contracted a URI. The cough is worse at night, but there are no other symptoms, and P is otherwise normal. What's the next step? An inhaled bronchodilator. She has acute bronchitis. We don't give antibiotics. Antihistamines can be very sedative, so we treat symptoms and perhaps an inhaled bronchodilator. 80. A 67-year-old male with confusion is brought in for a cough and is diagnosed with pneumonia. BUN is 24. What's the next step? Ceftriaxone, azithromycin, and admits to the hospital, because here we're dealing with a CURB 65 situation where the answer is inpatient, and remember, in such a situation, we have to treat the typicals and the atypicals. All right, 81, just to save you time here, we have a case of kind of like pneumonia, and we need to get a chest x-ray. We remember pneumonia requires imaging. In general, we want imaging for sure for the purpose of the boards. We want imaging to diagnose pneumonia and then treat it. All right, 82, a 63-year-old patient from China has 4 months of weight loss, cough, and hemoptysis, fatigue. CT scan is shown. How is the diagnosis made? So again, this is aspergillosis, and therefore we want to get a serology. That's how we diagnose aspergillosis. And remember the treatment, an antifungal, voriconazole, and surgical resection of the aspergilloma. Actually, aspergillomas are often typically discovered incidentally in patients with pre-existing lung disease, such as sarcoidosis or TB. 83. So here you have a cave guy. If you ever see caves with lung conditions, think histoplasma. We have to know where this guy has traveled to a cave. All right, you can take a look over here. Here we just want to know with these lab values, protein, serum, LDH, what type of effusion is this? What is the mechanism of this pleural effusion? It's an exudative effusion because the pleural protein over serum protein is more than 0.5. So it's exudative, and that's caused by increased capillary permeability. 2-year-old boy with croup has had an inspiratory stridor. He should be given dexamethasone and nebulized epinephrine. Croup, when it gets worse, we want to give nebulized epinephrine. Intubation only if it fails or we see signs of impending respiratory failure. 86. What's the mechanism involved in the condition associated with the image? I saw this as a UWorld question, or similar to it. This is, of course, croup. The obstruction is through the edema. The narrowing of the proximal trachea caused by the edema. 87. A 33-year-old woman with no signs of DVT comes into the ED with shortness of breath and heart rate of 94. D-dimer is normal. She has a history of cancer. What's the next step? We ought to give reassurance. There's no reason to assume that because she has shortness of breath, there's a problem here. We're not going to assume that there's a pulmonary embolism here, and this is based on the Wells criteria. Nothing indicating, no strong indication for workup for pulmonary embolism. 88. A 36-year-old female with multiple sclerosis who uses a wheelchair comes to ED for left-sided chest pain and shortness of breath, which is getting worse. Chest x-ray shows a small left-sided effusion. What's the diagnosis? So this over here is actually a case of pulmonary embolism because we have such a sudden onset. We also see tachycardia over here. And of course, the fact that she was immobilized makes us think of pulmonary embolism. What is the most common cause of cor pulmonale in the US? COPD. Remember, cor pulmonale refers to right-sided heart failure without left-sided failure from pulmonary hypertension. 90. A 67-year-old male with confusion is brought in for cough and is diagnosed with pneumonia. BUN is 24. What's the next step? Remember, ceftriaxone and zithromycin. Remember, curve 65. We want to treat the typicals and the atypicals. 91. A 31-year-old male non-smoker has 3 days of fever, malaise, and cough, which produces clear sputum. Chest x-ray. Actually, whoopsies, we already had this question. And we already had this question. I guess I had repeats over here. Aspergillosis. All right, good review. Histoplasma. All right, this feels really good. We're going really quickly through these questions without actually having to do them because we already did them. And here we have, and again, cor pulmonale, COPD. Question 100. A 54-year-old woman with chronic kidney disease has acute onset shortness of breath. VQ scan shows right upper lobe pneumonia. Defect with good ventilation. What's best initial treatment? Unfractionated heparin. Anticoagulation is required for PE right away unless contraindicated, and we give unfractionated heparin, and this is preferred over low molecular weight heparin in patients with severe renal insufficiency. And that's because reduced renal clearance increases the anti-XA, anti-10A activity levels and bleeding risk. So you want to give the CKD patients unfractionated heparin. Now, just a note over here, I wrote in green that prophylactic anticoagulation does not eliminate the risk of acute pulmonary embolism, especially in high-risk patient populations. And the CT pulmonary angiography is the initial diagnostic test of choice in patients with likely pretest possibility of acute pulmonary embolism. 101. Exertional dyspnea with increased transmitral flow velocity is seen in rheumatic heart disease. That's what we see in mitral stenosis in rheumatic heart disease, leading to this exertional dyspnea. 102. Respiratory distress, petechial rash, fat embolism. It can occur following fracture of large marrow-containing bones. There's a triad of respiratory distress, neurologic dysfunction, and petechial rash. But this rash is only present in less than half of cases. 103. CVP is elevated and PCWP is low. This is seen in pulmonary embolism. It can cause an obstructive shock, so we have a low or normal PCWP because there's an intact left ventricular function. It's the pulmonary vasculature that is affected. 104. Intermittent fever, malaise, weight loss, rhinosinusitis, tracheal narrowing with ulceration, elevated creatinine, and this is seen in granulomatosis with polyangiitis. I liked it better when they called it Wegener's granulomatosis, and we see these symptoms over here. Nosebleed, crusting of the nose, stuffiness, and runny nose. Saddle nose deformity and hearing loss, all seen in Wegener's granulomatosis. 105. Congestive heart failure caused an effusion with a pleural fluid pH of 7. Whoopsies, that was a mistake. It should have said 7.51. Normal fluid pH is basic, 7.6. When it's transidative, i.e. heart failure, it's going to be between 7.4 and 7.55. So the answer over here is 7.51. Here I'm too lazy to read through the question. The answer is AV malformations. And we were describing this case, nosebleeds. Nosebleeds, hereditary hemorrhagic telangiectasia, Osler-Weber-Rendu syndrome. That's what's going on over here. 107, right side heart failure, crackers in lower extremity edema in sickle cell patients is usually due to chronic intravascular hemolysis due to pulmonary hypertension, seen fairly commonly in sickle cell disease. This involves chronic intravascular hemolysis causing pulmonary vascular remodeling, and we see dyspnea and right-sided heart failure. 108, a blank-year-old man with hypertension and obesity gets into a car accident. What's the next step? Nocturnal polysomnography. We want to figure out if he has obstructive sleep apnea causing him to get tired. That's why he got into the car accident. 109, a postpartum patient with sudden onset shortness of breath had a well score of 6. What's the next step? IV heparin. She has the criteria, and this comes before the CT angiography or VQ scan. Anticoagulation should precede any diagnostic testing. All right, this is the last question I'm going to go through, and the rest I'm just going to show you the slide. What is seen in this CT scan is a pulmonary embolism we see over here. It may show a peripheral wedge-shaped infarction, and this is virtually pathognomonic for pulmonary embolism. All right, you can take a look at these questions over here on pulmonary arterial hypertension, obstructive sleep apnea in a child, often due to adotonsillar hypertrophy, Goodpasture syndrome, air embolism. Patients should be put in their left lateral decubitus position. Another question on granulomatosis polyangiitis. Patients should be tested for autoantibodies. Smokers getting chest wall restriction. Here I have an interesting question on ankylosing spondylitis. The cause of their respiratory symptoms is actually a mechanical problem, chest wall restriction. Here we have sudden onset shortness of breath, hypotension, tachycardia. Think of a pulmonary but we have unilateral absence of breath sounds. That's most likely a pneumothorax. And this could follow positive pressure ventilation. It compresses the mediastinum. Extubation readiness includes all of the above. This is more of a surgery question. All of the above. Patients who meet these criteria should undergo a spontaneous breathing trial to help confirm candidacy for successful extubation. Orthostatic hypotension, decreased urine sodium. And that's because when there's hypovolemia, there's increased renin, more potassium out, more sodium in, decreased urine sodium. Here we spoke about this kind of at the beginning, the diffuse alveolar hemorrhage caused by cocaine. And we try to save their life. 122, ACE inhibitor cough is due to impaired metabolism. As ACE is usually involved in the metabolism of kinins and substance P, so ACE inhibitor therapy leads to reduced breakdown of these molecules. 123, acute benzodiazepine intoxication causes respiratory acidosis, because it causes a decreased respiratory drive leading to hypoventilation and respiratory acidosis. Here we just have heart failure, chronic heart failure exacerbation. That's what's going on over here. You could take a look at the explanation. Here's a question on ARDS, which we didn't discuss yet. Characterized by impaired gas exchange hypoxemia, decreased lung compliance, and increased pulmonary arterial pressure. And again, you could take a look over here. Question 126, this is a 9-year-old girl with asthma. We want to change the regimen. She's only on daily fluticasone, but she has more of a persistent symptom. She would benefit from a LABA, such as salmeterol, and steroid for prevention of symptoms. 27, what do we do in a case of an axillary lymph node in such a case? We want to get an axillary node biopsy. It's less invasive than a transbronchial lung biopsy. 25, what do we do in the next step over here? Remember, if there's a concern for a pulmonary embolism, you want to give the heparin bolus before the diagnostic testing. 129, treatment of tension pneumothorax is first. Needle decompression for tension pneumothorax. 130, complicated parapneumonic effusions are treated with, and the answer is antibiotics and chest tube placement. It's not enough to give antibiotics. Here's just a chart from UWorld, where we talk about the differences between uncomplicated and complicated parapneumonic effusions. All right, that's it for this lecture over here. I really hope you enjoyed. And again, stay tuned for some super awesome updates to ajmonix.com. Take care.